Hi, welcome back. This is Dr. Sandeep Patil, a laparoscopic surgeon from Yashoda Hospital, Mumbai. Today I am posting a surgical video on hysteroscopic resection of a small FIGO 3 fibroid done for fertility. This 28-year-old housewife who was keen to conceive had previous 3 failed IUI. She underwent IVF cycle with vitrification of embryos. While waiting for embryo transfer, she was posted for pre-IVF hysteroscopy as her pre-op USG was showing 2.5 cm FIGO 3 fibroid. In recent years, we have adopted to vaginoscopic approach for hysteroscopy. While our hysteroscope is navigating into cervix, you can see external os showing erosion and hysteroscope is entering in the cavity. The distension medium he used here is a normal saline, and you can notice a significant endometrial debris or sloughing is seen as a floating debris in the fluid. This floating debris is nothing but shredded necrotic tissue or endometrial flakes, which may be seen in conditions like endometrial hyperplasia, endometrial atrophy, infection, and after hormone withdrawal bleeding. It obscures field, and that's the only nuisance, and if we stay there for some time it gets cleared off. At the max we need to adjust focus of our hysteroscope just to fine tune the vision. Once this nuisance gets cleared off, we can notice a small bulge at fundo anterior aspect of the cavity, and that's the impression of underlying small fibroid. This is seen as smooth, pale bulge with minimal protrusion into endometrial cavity. This is characteristics of FIGO 3 fibroid. The FIGO 3 fibroid is completely intramural. At the same time, it is abutting the endometrium without protruding into cavity. This fibroid is not submucosal but very close to the endometrium. Imaging modalities can just confuse between submucosal and intramural fibroids. Once we locate the fibroid, next step is endometrial incision over the fibroid. A vertical incision is made on overlying endometrium using bipolar cutting loop to expose the fibroid capsule. The fibroid is gently dissected by slicing in small controlled chips. Intracapsular mobilization by cold loop is also done for bigger fibroids, which helps us to save the time. This technique helps to displace the fibroid further into cavity, making resection easier. Care is taken not to breach the myometrium deeply to avoid perforation. Since this fibroid is small, we did not attempt intracapsular mobilization with cold loop. This fibroid is progressively debulked. Chipping continues until the fibroid is fully removed, layer by layer. If any bleeding is encountered, bleeding vessels are to be coagulated carefully using bipolar energy, minimizing thermal damage to surrounding endometrium. Bleeding during this surgery is not a good sign. It may suggest that you are resecting into wrong plane, fibroid is very vascular, or you are going near the serosal layer, or you have already landed up into perforation. Intramural part of the fibroid is bit difficult to resect as compared to FIGO 0, 1 or 2 fibroids. We literally need to dig into fibroid and do resection. This digging should not be too deep. We need to resect fibroid in very thin strips to avoid perforation. One need that eye or vision to differentiate between normal myometrium and fibroid tissue. Fibroid tissue is more firm, rubbery, and ivory white in color and less vascular. The whorl pattern of fibroid is having typical irregular surface, while myometrium is more elastic, smooth, and pink due to its vascularity. We give post-operative estrogen therapy to promote endometrial healing with progesterone for withdrawal for a couple of months, and then the patient is ready for further fertility treatment. In selected cases, second look hysteroscopy is performed after 3 months to assess cavity restoration and to detect adhesions. Here you can notice final look of the cavity. and see a nice deep crater is seen due to complete resection, while entire normal cavity is also seen with openings of bilateral fallopian tubes. There is no residual fibroid tissue remaining. Some fibroid beads are seen floating in the cavity, which will come off later on its own. To conclude, hysteroscopic resection of FIGO 3 fibroid requires surgical procedure and good anatomical orientation. With appropriate case selection and technique, it offers minimal invasive fertility preserving option for symptomatic women. Thank you for watching this video. We will meet soon for similar video in near future.